Okay, so good morning, everyone. I'm Margareta Brandt. Welcome to the Investment and Payment Work Group this morning. This is our 14th meeting of the work group and our second meeting focused on behavioral health investment. So really happy that you all are here this morning and able to join. Please go ahead and introduce yourself in the chat with your name and organization. And we'll also have an opportunity in a bit to invite folks, work group members who were not able to join us last meeting to introduce themselves in a bit. And so moving to our agenda. And before I review our agenda today, I did focus on behavioral health. I did want to provide an update on our primary care investment work. So as many of you know, we had been working towards presenting our primary care investment benchmark to the board for approval in August. And we will now be presenting our primary care investment benchmark to the board for potential approval in September. So we plan to present that in September. And as some of you all know, or some of you know, that the August OHCA board meeting is in Monterey, and there are lots of kind of robust discussion topics that the team wanted to cover in that Monterey meeting. So we will be seeking board approval for the primary care investment benchmark in September. So wanted to share that update with you all, as I know you've been, many of you have been participating in the primary care work as well. So getting to today's agenda, we again will do some brief updates and introductions of any work group members who weren't able to join at our last meeting in July. We'll do a recap of the July work group meeting. Just since we had such a robust discussion, we wanted to provide a refresher of where we were in July and what we presented in July. And then we'll review quickly our data collection approach for behavioral health spend measurement. And then we will also continue discussion on goals for increased behavioral health investment. And here we're really looking to kind of land on some general consensus goals in this work group that will help guide our work moving forward. And after each agenda item, of course, we will pause for questions and discussion. And this is just a reminder of our usual meeting format, and a note. I think the emphasis here is that please feel free to add questions or comments in the chat. We may not be able to respond to all questions or comments during the meeting, but we keep track of them, and either we'll get back to you or we'll follow up with them in the next meeting and use them to inform our work going forward. And so I think then getting into our investment and payment work group members and those newly joining for behavioral health, wanted to have the opportunity for several of you all to introduce yourself if you were not here during our July meeting. And also wanted to welcome a new work group member, Stephanie Berry from Elevance or Anthem. And Stephanie, would you like to introduce yourself to the group?
Hi, good morning, everyone. I'm Stephanie Berry. I joined Anthem a few months ago as one of their state government relations directors.
It looks like you're unmuted, but I can't hear you. Can other folks?
I can hear her.
I can hear also.
Yeah, me too.
I can hear as well.
Oh, sorry. Hi, I joined Anthem in April, and but I've been in the behavioral health and health plan space for a number of years, and I'm really looking forward to working with this group.
Wonderful, thank you. So, and wanted to check if any other work group members who were not able to join us in July would like to introduce themselves. I'm just checking to see. I guess maybe Nina, are you on the line, or Pallav? Or Vicki Mays? And then maybe Amy, Amy Nguyen Howell, I think you weren't able to join us in July. Are you able to introduce yourself to the group?
Sure. I'm Amy Nguyen Howell. I'm not new to the group, and I'm a family doc and leading provider advancement. So, hi everyone. I was in Scandinavia and Europe, so I'm still kind of floating that high from the Olympics. So, thanks, Margarita.
Yeah, thank you, Amy. Okay. Okay, I think we captured most folks, but please, of course, jump in if you are a work group member and weren't able to join in July and would like to introduce yourself. Please just go ahead and raise your hand. Okay, so now we'll kick it off with our first agenda item, and I'll turn it over to Debbie to provide a recap of our July work group meeting.
Thanks, Margareta, and good morning, everyone. I'm Debbie Lindis. I use she, her pronouns, and I am the Healthcare Delivery System Group Manager here at OHCA. So we'll kick us off with a recap of the items that we discussed last month. And so to begin at a very high level, these are the three key components of OHCA's work to ensure healthcare affordability for consumers and purchasers in California. So our core statutory activities include work to slow spending growth, assess market consolidation, and promote high-value health system performance. So within our work to promote high-value health system performance, OHCA has 5 focus areas that you can see on this slide. And as we reviewed last meeting, our behavioral health investment work will focus on defining behavioral health for the purpose of measuring spending and then on setting a spending benchmark. OHCA's focus on behavioral health investment is due in part to increasing prevalence of behavioral health conditions, the recognition that access to services is often lacking, and also the strong body of research that finds addressing individuals' behavioral health needs both improves their overall health outcomes and lowers healthcare costs. So our behavioral health investment work will be guided by the statutory requirements and goals that are outlined on these next 2 slides. And so to review those, OHCA is required to promote sustained system-wide investment in behavioral health care, to measure the percentage of total healthcare expenditures that are allocated to behavioral health, and to set investment benchmarks. To complete those tasks, we will determine the categories of diagnoses, providers, care settings, and specific procedure codes, as well as non-claims payments that should be considered when determining the total amount spent on behavioral health. Throughout our work, we'll be consulting with sibling state departments and external organizations promoting investment in behavioral health, as well as other entities and individuals with expertise in behavioral health. And OHCA will include an analysis of behavioral health spending and spending growth in its annual report. So as we launch our behavioral health workstream, it's helpful to keep these statutory goals in mind. As we're forming our recommendations, we will seek to promote improved behavioral health outcomes. And this context is important because it's a reminder that measuring behavioral health investment is not an end in itself. It's a tool to help policymakers and the public understand where resources might be needed to correct longstanding issues in behavioral health, such as underdiagnosis, lack of access, and inequitable outcomes. OHCA can center these issues through its benchmarking, which may focus on high priority areas for investment instead of setting a target for across-the-board behavioral health spending. And later this morning, we'll talk more about how OHCA can promote improved outcomes within its statutory scope. So this slide includes a really important graphic that we discussed last month. It's from the Milbank Memorial Fund report, Recommendations for a Standardized State Methodology to Measure Clinical Behavioral Health Spending, which was written by our colleagues at Friedman Healthcare and published this past spring. So the graphic here defines the components of behavioral health spending that could be included in state measurements. The section of the graphic that's shown in color refers to clinical behavioral health services that are paid for by healthcare payers like commercial health plans and public payers such as Medi-Cal. To define spending, OHCA is focused on those services that are part of total healthcare expenditures. So that's these clinical services that are paid for by public and private payers through claims and non-claims payments. And we recognize that this is a relatively narrow view of behavioral health spending. In the future, OHCA will be exploring the possibility of using supplemental data sources to capture other spending, such as some of those that are shown in gray on this slide. And we also want to re-acknowledge the significant direct spending by consumers for behavioral health services. While OHCA's current data sources will not be able to quantify that spending, OHCA does plan to study out-of-pocket, out-of-plan spending or self-pay spending for behavioral health as part of a separate work stream. And we'll be collaborating with that team to ensure that insights that are shared here are incorporated into their work. So moving to the slightly more technical parts of our measurement, similar to our approach for measuring primary care, OHCA proposes to use 3 modules to measure behavioral health spending. And these are behavioral health care paid via claims, behavioral health care paid via non-claims, and behavioral health in primary care. The behavioral health in primary care module will be measured separately so that we can include it in analyses of either behavioral health or primary care spending. And the work group defined that module as part of its primary care work. Over our next several meetings, this work group will be informing the behavioral health care paid via claims and non-claims modules. And it will also weigh in on whether any adjustments should be made to the behavioral health and primary care module. I want to point out here one potential important difference between our approach to behavioral health versus primary care investment, which is that while we will measure overall spending on behavioral health care, our investment benchmark may focus on a subset of conditions, care settings, or populations that are a high priority for increased investment. Unlike primary care, which occupies a specific place in the healthcare continuum, behavioral health care is treating specific conditions across the entire continuum of care. And so while increased primary care across the board is desirable, and this is reflected in our primary care investment benchmark, increases in some types of behavioral health care may serve OHCA's goals much more effectively than others. So a more focused benchmark for behavioral health spending would acknowledge this. And we'll discuss the benchmark focus more in a few minutes and also at future meetings. And so for now, I just wanted to re-emphasize that the benchmark may not attempt to account for overall spending on behavioral health as captured by these 3 modules. So this slide is a reminder of what we showed last month, which is our proposed phased approach to defining and measuring behavioral health spend. Our initial measurement definition and data collection will focus on commercial and Medicare Advantage markets. And then the next step will be to adapt that commercial market definition to the Medi-Cal market, making refinements as needed. And this work may also consider some of those data sources that are specific to Medi-Cal. And finally, we'll revise the definitions over time and iterate as needed. So our discussion at the workgroup's July meeting focused on the issues I've reviewed already and others that we'll need to navigate in defining and measuring behavioral health spending. So we've summarized these into 3 categories. The first is related to the reasons for measuring behavioral health spending. Workgroup members pointed out that the behavioral health spending OHCA measures will not capture all spending. And importantly, measuring spending does not directly reflect unmet need, underdiagnosis, inadequate access, for which there should be spending, but there is not. Another purpose of measuring spending is to monitor progress toward a benchmark that will reflect our goals for improving the behavioral health system. We talked about OHCA's strategy of initially focusing on spending by payers for clinical services as part of our existing plan to collect data on total healthcare expenditures. And we noted that future approaches may include additional data sources to bring a more comprehensive view of behavioral health spending. Other topics were discussion of the proposed phased approach to measuring behavioral health spending, starting with commercial and Medicare Advantage, an acknowledgement of the importance of measuring substance use disorder treatment spending, and the idea that a targeted approach to increased investment, as expressed through focused benchmarks, may have the greatest impact on system improvements. So following our last meeting and other recent discussions, we want to emphasize these points about actions OHCA is taking to support the workgroup's work. The OHCA will continue to learn from our sibling departments, which are represented in the workgroup, and consider variations in definitions of behavioral health in developing OHCA's definition. We're mindful of the limitations of measuring behavioral health spending as part of total healthcare expenditures. And to supplement our measurement, we will be exploring possible ways to measure other spending, such as out-of-pocket spending and services paid for, funded by the Behavioral Health Services Act in the future. We'll note how current levels of utilization and spending do not reflect population need due to gaps in access to behavioral health services. And we'll continue highlighting how increasing behavioral health investment can help OHCA meet its statutory requirement to promote better behavioral health outcomes for Californians. So I want to pause for a moment here for any questions or comments about this proposed high-level approach to measuring behavioral health spending in the slides I've covered so far. We will be discussing our goals and priorities for spending later in the meeting, and so we'll allow plenty of time for a broader discussion at the end. But any comments? Yeah, Kirsten.
Hi, I'm sorry I'm not quite on video yet. Kirsten Barlow with the California Hospital Association. Thanks for the overview and kind of reminding us where we came from so far. One thing I would just really urge this work group and maybe OHCA more broadly to consider is to kind of avoid using the term behavioral health system, because I think that kind of continues to perpetuate the idea that there is a system, typically a publicly run one, that is solely responsible for providing behavioral health care. And as we know, and as indicated by the scope of what we're looking at here, we wouldn't ever refer to like the cancer system. So I think we want to make sure we're referring to behavioral healthcare services, because those are supposed to be occurring across the healthcare landscape, not by any one system.
Thank you for that. Let's see, Katrina.
Yeah, thank you for the presentation. And just in the previous slide where it says why measure behavioral health spending, and then the first bullet says understand baseline, recognizing it does not reflect unmet need, underdiagnosis, or inadequate access. I think it's probably also important to state that part of the inaccuracy or the inability to come up with a complete measurement is also because of certain policies, such as the inability for FQHCs to bill for the same day for behavioral health and medical, because what might happen is the clinic might provide the service on the same day, but that's not captured because of the inability for same-day billing. So I think it's important to also capture that and recognize that when we're understanding the baseline.
Thank you. That's a great flag of an important limitation. Carrie.
Hi, good morning. Carrie Sanders with CPEN. Just want to kind of add or appreciate the HCI for not measuring behavioral health, as a whole, but actually looking at sort of the bands of spending and where spending is going. I think for us, we don't know that there is necessarily evidence that spending more in certain places will lead to better health outcomes. And so I think it's for that reason, it's really important to us that we are, taking a very close look at the spending amounts, but also where that spending is being targeted and whether, it is or isn't leading to better health outcomes. And just, to add, I think one of the main pain points for consumers is really around the mild to moderate spectrum and part of that continuum. And in particular, the availability, cost, affordability of services and whether they're meeting consumer needs. So just, look forward to those discussions. But I did want to appreciate HCI for, sort of that the approach that we can't just, we can't just do, blanket spending targets when we're not really breaking it out by the type of service. Thanks.
Thank you, Carrie. And Beth.
Yeah, just to emphasize again how different behavioral health is than the primary care, where we all knew we needed to do more. I think we need to do different. And I think I also want to just thank the OHCA team and the consultants for having a much richer discussion than last time, and broadening our focus beyond the subset of spending that is called total healthcare expenditures, which really means spending by health plans and insurers. I think especially for behavioral health, it's important. The third point I'd make is that out-of-pocket spending by consumers is a major source of inequity. For the 80% of Californians who live in households that make less than $146,000 a year, maybe the families making $100,000 or $120,000 a year can afford to pay out of pocket for necessary behavioral health, but lots of Californians just can't, and that worsens the inequities that so many and the disparities that so many already face. So I think that's an important addition, and but I just want to focus on the multiplying inequities in the behavioral health space. Thank you.
Thanks, Beth. Looks like next is Janice.
Thank you. Part of partially a question and partially a maybe topic for brainstorming in the future. And first, I would say I agree with everything that Beth just said. But in terms of the question, since we're going to, in the short term, focus on THCE in terms of measurement, can we think about, in terms of trying to collect as much data as we can about what folks are spending in terms of out-of-pocket expenditures? It seems to me like it would be a variety of things in terms of like patient surveys, talking to primary care docs about what they know about when they're trying to refer folks for care and when they end up having to pay out of pocket because they can't find somebody in their network in a timely manner, or talking to the behavioral health workforce themselves and figuring out what percentage of their patients are having to pay out of pocket because their insurance, they're not in the plan of some of their patients versus they are contracted with others. So just sort of trying to figure out what the space is here, what the reasons are, so that we can figure out the solutions.
Thanks, Janice. And I think just to clarify, are you kind of suggesting or proposing that we look at different ways to measure out-of-pocket spending on behavioral health, or out-of-pocket, out-of-plan spending on behavioral health?
Yes, both measurement of it and figuring out why folks are having to pay out of pocket. I mean, we know generally speaking, but so that we can push changes so that that's not the ongoing situation.
Okay.
Yeah, I would say this is, Beth again with Health Access, there's a lot of work on consumer affordability that the OHCA has already seen. I know there's survey data specific to behavioral health. And we also have DMHC doing some targeted investigations on behavioral health access for their regulated plans, which is an important piece of work. And the third resource I'd point to is the NUHW also did a lot of work in this area with respect to Kaiser patients and beyond. So I think thank you, Janice, for raising that. You point to a lot of resources that already exist. So, but it won't be, none of it, I don't think anybody on this meeting will think all of that taken together is sufficient, but it'll certainly give us some better sense of the scope of the problem.
Okay. Great. Yeah, thank you for those suggestions and resources, and we can bring those back to the group working on that out-of-pocket, out-of-planned spending analysis, and also consider, how that we can bring that into our work more directly. I think, sorry, someone else had their hand raised as well.
Yeah, Kirsten.
Hi, guys. Just a kind of thought for us to think about and maybe get some feedback from the folks leading the work of this work group to give us a sense of whether we can talk about this at some point, which is it kind of builds on what CPEN was saying about how some kinds of spending have more value than others, and would encourage us to come up with a more discrete way of looking at, quote, behavioral health spending beyond just saying, oh yeah, and we want to capture alcohol and drug treatment, because maybe kind of similar to my earlier comment about cancer, we wouldn't just look at all kinds of cancer. There are lots of different sorts of mental health and substance use disorder conditions. And so, I think it's not a homogenous population, and the treatment and spending that we are doing or should be doing is also not homogenous. So would really like it to be discussed at some point what we mean by behavioral health, and whether we want to maybe assign some, I think CPEN mentioned bands of spending, but also just kind of population subgroups to look at in a more discrete way than just kind of lumping this as one great big chunk of spending and population.
Thank you. Yes, that's definitely a consideration for both our spending definition and our benchmark. So we will get into much more details in the coming meetings in terms of how do we define behavioral health spending and what's included. And then also how do we set our benchmark, and is it all behavioral health spending, or is it a subset of behavioral health spending where we want to focus investment? So those will be key considerations for our future work group meetings. And Hector, go ahead.
Thanks. Just really quickly, because I agree, and I think it's great that we're going to have more opportunities to discuss this later on. But I just wanted to agree with that sense that we got to think about the different types of treatment available. And I think something that's really helpful is in the behavioral health context is to think a bit about the differences between settings and services, right? Because we often think of services particularly in the SUD context, but it's happening more and more in the mental health context as well as residential treatment or outpatient intensive treatment, or which a lot of times talk about where the person is receiving the treatment rather than what exactly is the service about, right? We can talk about residential treatment, and then within residential, there's a bunch of services that could be provided, and those services could be good, or they could be not as effective. So I think it's helpful to think along those lines in behavioral health along lines of what are the settings, how are we investing in settings, what are the funding is going to settings, but also what are the services that we're seeing being invested on. Thank you.
We saw the doctor and it looked like.
Thank you, Hector. Anyone else have thoughts or suggestions before we move on to data collection? And I see a few comments in the chat, so we will take note of those, and I think we can try to answer some of those questions today or in our next meeting. So I think we can hand it off to Bob. Yeah.
Thank you. Good morning, everyone. We're going to spend the next few minutes now talking about OHCA's approach to data collection, at least initially, for measuring behavioral health spending. And then we'll discuss how OHCA's statutory responsibilities, which we looked at earlier, to measure and benchmark behavioral health spending connects to making the improvements in behavioral health delivery and outcomes. So to begin, OHCA will collect data to measure behavioral health spending from the same entities that will submit data for measuring total healthcare expenditures, or THCE. Behavioral health spending measurement is part of the overall THCE data collection effort. The statute requires that behavioral health be measured as a percentage of THCE. So for consistency and to minimize the reporting burden on data submitters, the data for measuring THCE and behavioral health spending will come from the same sources. Behavioral health spending data will include both claims and non-claims payments, as we saw earlier, with non-claims organized into the expanded framework categories. OHCA will set the standards for the definitions and the technical specifications for submission of behavioral health spending data and will offer technical assistance to support accuracy and consistency. This will be particularly important for the non-claims portion of spending, which will likely involve allocation methodologies that go beyond the method on the claims side, which involves applying clearly defined code sets. And OHCA's initial efforts at measuring behavioral health spending, as we've seen, will focus on the commercial and Medicare Advantage payers and their members. OHCA will begin measuring behavioral health spending as part of the 2025 THCE performance year submission, which is due in September 2026, 2 years from now. Following the phased approach we have discussed, OHCA will use the THCE data that commercial and Medicare Advantage payers submit to measure the behavioral health spend. The data will include fee-for-service payments for behavioral health claims and non-claims payments allocated to behavioral health. These non-claims payments will include capitation payments, performance payments, payments to support integrated behavioral health, and other sorts of non-claims approaches. If a full-service health plan carves out behavioral health care, meaning they contract with a behavioral health service plan to manage and cover their patients' behavioral health care, the payments that the full-service health plan makes to those specialty plans are included in the full-service plan's submission. These payments may not have the same level of detail as the full-service plan's direct payments to providers if, for example, the carve-out plan is receiving a per-member per month payment from the primary plan and is therefore not submitting claims to that primary full-service plan for the services it provides. So to conclude this section, we have a few discussion questions. We'd love to get some feedback from you on what I've just described. We'd like your insights on these data sources, excuse me, and in particular, the relationship between behavioral health carve-out plans and the full-service health plans with which they contract. So in your experiences, what is the level of detailed information that is transmitted between the full service and carve-out plans? Does it vary for fee-for-service versus capitation payments? Or does it vary if the full service plan is a fully insured plan or a self-insured plan? We're trying to really get a good handle on the nature of the data that will be submitted, and any insights you have to offer at this point are welcome. I will pause it here, turn it back to Margareta to see if there's any discussion on this. Thank you.
Thank you, Bob. Yeah, any thoughts on, and especially folks who participate in, these plans, or have insight into how the data sharing works between plans, want to provide insight or any more questions to add that we should look into and explore? Yes, Sarah.
Well, hi everyone, Sarah Arnquist, consultant, formerly employee of one of those carve-out plans. And there are others here who can talk to. So there's usually two types of relationships. There's like an ASO relationship and a risk-based relationship. In the ASO relationship, where the carve-out plan is sort of purely administering the claims and processing them, but the health plan is funding them, all of the detail would certainly get back to the health plan. And then in a full risk relationship, I still think if not most or all of the detail would also from an account would come back to the plan as encounters. So I think it would be pretty reliable to assume that most of the detail is getting rolled up, but others can speak too.
Thanks, Sarah. Nicole, go ahead.
Yeah, just to confirm, so Nicole Stelter from Blue Shield, to double down on what Sarah just described, we're one of the plans who does a fully insured carve-out, and we do get both claims and encounter data back, so would expect to have pretty complete information available.
Thank you, that's helpful. Beth.
There was a good question in the chat from Kirsten about why commercial and Medicare Advantage. I would have I think I know on the physical health side sort of why Medi-Cal is not the focus, but I think on the behavioral health side, the complexities of public funding of behavioral health, drug Medi-Cal, county mental health, as well as the traditional Medi-Cal managed care and the small fraction of Medi-Cal fee-for-service, it suggests to me that it's a pretty complicated book of business you're looking at with Medi-Cal. But if you could spend a minute or two saying why I'm guessing here that that's why you're starting with commercial and Medicare Advantage, but if you could spend a minute or two explaining, it'd probably be good for all of us to hear. Thank you.
Sure. So there a few reasons. So one, OHCA's initial data collection is from commercial plans, which includes, their commercial individual business and Medicare Advantage. So we are, starting, in a few weeks, we are collecting our first initial data collection from commercial plans. And to start with measuring Medi-Cal spending, we are working very closely with DHCS to use different data sources. So to measure Medi-Cal health plan spending. So we are looking at, different reports from DHCS and CMS to measure Medi-Cal spending. So as many of you know, and if there are other OHCA folks or FHC folks on the line that want to weigh in, for our initial year of data collection, Medi-Cal managed care plans are not submitting data to OHCA. They were given like a 1-year extension. So that is part of the reason that we're focused on commercial first. And then also, Beth, as you emphasized, that, the Medi-Cal and behavioral health system is quite complex. So we are working closely with DHCS to kind of have some initial conversations with them to understand what are the parameters, how we could measure it. And then, once we all kind of have a better understanding, or at least, the OHCA team has a better understanding of how we could approach this, we'll be bringing those discussions to the work group. So it's a phased approach of starting with commercial and Medicare Advantage, generally tied to, since that is where our data collection is starting, and then as we move forward, transitioning to Medi-Cal.
So if I could just follow up, and you may have just, in answering my question, misspoken. You said commercial individual market. I assume it's the entire commercial market.
Sorry, entire commercial market. So including, yes, thank you.
And then we'll get here eventually, but at some point we should probably talk about Medicare Advantage versus Medicare fee-for-service, given that half of those on Medicare are in, or roughly, are in fee-for-service. And somebody's bound to have that question at some point. Thank you.
Sure. Kirsten, is that you?
Yeah, thanks. Let me know if this is too involved a question. But for those of us who are kind of coming into the OHCA process, really more from the behavioral health piece and haven't followed all of the work you're doing on primary care, I'd like at some point to help understand how the data gets collected. I was assuming that particularly for claims-based data, you would just be getting it from, well, at least on the Medi-Cal side, you can get that from the state. So can you help us understand, you said plans have to report the data. What does that look like? Is that a huge exhaustive question to have to answer?
Well, it can get quite complicated depending on how detailed we want to be. I think at the highest level, we'll say that OHCA has a data collection process where we collect aggregate spending data from the health plans. So we are getting aggregate spending data kind of broken out in a variety of ways, and one of which will eventually be primary care spend and behavioral health spend, and then also alternative payment models. So we are getting essentially rolled up or aggregate claims data and aggregate non-claims data. We are not getting like individual level claims data. So that's the very high level answer. And if there's anyone else on the team that wants to weigh in and add any context, please do so. And we can also, since I know some folks new to the behavioral health work stream, maybe we can provide kind of an initial layout of how OHCA is collecting data in one of our upcoming meetings more broadly, so you all have that context in terms of how OHCA is collecting data and what
maybe just as just a follow-up maybe. So I'm maybe confused. So if you're only getting aggregate spend, how is it is this a phase in again of the point where we start to look at, well, we want to look at specific kinds of spends and specific kinds of bands, as was mentioned earlier? That's something that would happen down the road, because at this point it sounds like you're just getting aggregate spend, right?
Yes. So, and there are a few nuances we can, in how we approach that aggregate data collection. We may be able to break it out in a few different ways. And then also we can use California's all payer claims database, which is the healthcare payments database, HPD, that is also housed within HCI to do more detailed analysis. And Vishal, did you want to add?
Hi, everyone. I'm Vishal Pagadi, Deputy Director for OHCA. Yeah, I just want to add, yeah, the OHCA data is a separate submission. It is summary level data. So we'll get kind of rolled up spending, like inpatient spending, professional is a category. So right now, for the first round of submission, professional is just kind of this broad category of professional spending. And then later on, as we, this work group has informed a lot of the definitions. So the next cycle of data submission will update the data submission guide and say these codes, these professional codes are for primary care, use these specifications, and then break it out in, professional would, become more disaggregated into other types of primary care professional, and then, eventually behavioral health professional. And it's the same thing for other categories like inpatient.
Thank you, Vishal. Mary Jo, did you want to add?
I might just add that, as a sneak peek to our discussion in September, folks may want to take a look at the Milbank report, which we can repost in the chat, which essentially lays out, a way that other states have approached behavioral health data collection and spending measurement, and the categories and sort of care settings and service types that they have broken the data into. Of course, that's not exactly the way that California needs to go. OHCA will be working with you all to develop that approach, but it does give sort of a framework to think about how the data collection might look. So we'll put that back in the chat, and that might be a good sneak peek ahead of our conversation in September.
Great, thank you. Any other data collection questions or thoughts on these questions that we've posed for discussion? Okay, so we will move to our next section of the agenda, which is focused on our discussion on goals for increased behavioral health investment. And here we really wanted to kind of continue our discussion on goals, since we didn't get to cover a lot of it during our last meeting in July. Here, and before we kind of jump into these key decisions, just as a kind of level set for the goals discussion, we really kind of use these goals to inform our work group decisions moving forward. So that's why we think it's helpful to at least have some common understanding of what are the goals that we are all working towards. So on this side, as a reminder, we have some of the key decisions that the work group will provide input on, and we've previewed some of these already in our discussion today. So, there will be decisions around what are the components of claims-based spending. So what are the diagnoses, the services, the providers, and the care settings that we include in a definition of claims-based behavioral health spending. And then similarly for non-claims, how do we define non-claims for behavioral health spending and allocate non-claims payments to behavioral health spending? And then also, of course, as we previewed, that we will look to define the benchmark focus. So, we want to measure all behavioral health spending, but is our benchmark more focused on a particular subset of that spending, whether it's by condition or care setting or population? And then determine the benchmark structure and timing. So are we looking at a 10-year benchmark or other options for the benchmark? And here, moving into some proposed goals. So these, this is a proposed set of goals for an improved behavioral health system that we previewed during our July work group meeting. And this list is adapted from a policy brief that was released by Cal HHS. The proposed goals are that for behavioral health care are that it should be accessible, meaning that it is culturally responsive and services are available when needed and affordable to all who need them, that it is comprehensive, that services are available across the care continuum, and that more treatment occurs in the community and healthcare facilities, and there is reduced need for behavioral health services in correctional facilities. It is coordinated, so behavioral health services should be integrated with primary care and the treatment of co-occurring chronic conditions, and should be attentive and responsive to health-related social needs. Another goal is that it is equitable, that there is reduced misinformation and stigma and discrimination, and also reduced disparities in utilization and outcomes. And of course, high quality, so that there is high satisfaction and low frustration with behavioral health services and improved outcomes for behavioral health services and care. And so we think these are all really important goals and can act as a guiding structure for some of our decisions and some of our work in the work group, but really want your feedback, and we'll pause for discussion in a bit. And again, wanted to illustrate here how we see OHCA's role in supporting improved behavioral health outcomes and supporting those goals. So this is a logic model that we developed to try to demonstrate how we see OHCA's role in this work. So the box on the far left shows the OHCA key components that you saw earlier, that Debbie previewed earlier. So of course, slowing spending growth, assessing market consolidation, and promoting high value. And then within promoting high value is our behavioral health investment work. And then within our behavioral health work stream, the work group is really focused on, promoting sustained system-wide investment in behavioral health, measuring and reporting the % of total health care expenditures allocated to behavioral health, setting the spending benchmarks to support improved behavioral health outcomes, and conducting analysis. So OHCA's role is really in this, promoting investment through measurement, reporting, and benchmarking, which can support broader California stakeholder actions. So, and those could be, identifying and supporting higher value care, building and sustaining infrastructure and capacity, promoting behavioral health integration with primary care and social services and public health services, and reducing disparities. And so that OHCA's measurement, benchmarking, and reporting really support these broader actions by potentially a broader set of California stakeholders, which leads to hopefully our goals are, that the behavioral health care in California becomes more accessible, comprehensive, coordinated, equitable, and high quality. And next, wanted just to share some examples of how we think that might work. So starting, we can measure mental health and substance use disorder spending separately and show how the spending differs across those categories, and compare that to need as represented in prevalence data from other sources. We can also measure spending across service and treatment categories. So like we've been talking a bit today, primary care versus outpatient care or emergency care for behavioral health conditions, and highlight, that spending, those spending differences on different treatment categories, with the goal to rebalance care towards prevention and outpatient care. And then, as we've talked about a bit today, also is setting spending benchmarks that focus potentially on specific populations, services, or care settings to motivate positive change towards increasing investment in those areas and motivate progress towards the overall goals. So next, I want to pause for discussion and get all of your feedback on these areas. So, starting with the proposed goals for improved behavioral health system, is there anything missing? Do you all have any suggestions there? And then on the logic model we presented back on slide 22, do you have any feedback on that logic model illustrating our role in improving behavioral health? And then a few other questions in terms of how can OHCA illuminate challenges in the behavioral health system or in behavioral health access within its statutory scope, and then other information that we should use to guide our work. So I'll pause here for discussion and feedback. Let's see, Beth, I think I saw your hand first.
That's fine. I go first at my own peril on this topic. I would say, in addition to reducing, and I haven't had a chance to read the Cal HHS report yet. In addition to reducing mental health within our correctional system, and I would note, I hope this is no longer true, but at one point the LA County Jail was literally the largest mental health facility in the world, which is a travesty on so many levels I can't even begin to describe. I would also say that to the extent we're reducing use of the emergency room for mental health and substance abuse treatment, that's something that falls within the sorts of things OHCA will monitor, and that would be, I'm not quite ambitious enough to say this should be like asthma. We're doing such a great job managing asthma that a kid in the emergency room with an asthma attack can be treated as a system failure. But, if we can do it with asthma, we ought to think about whether we can do it with mental health and substance abuse treatment. And I know that's ambitious, and that won't happen in the next 4 years or maybe even the next 10 years. But part of the point of OHCA is to set those kind of long-term goals and help to steer our system towards it. The final point I'd make is I think we have to think beyond traditional health and think about what is normally called human services as well, because I think those matter a lot in terms of prevention. Thanks.
Great, thank you. And it looks like several folks agree with your recommendation of including reducing behavioral health in the emergency department. And Nicole, go ahead.
Yeah, more of a question. I was looking for maybe a definition on the logic slide under on that first column to the left. Thank you. The key components, workforce stability. Can we talk about, I guess when I'm thinking about kind of the workforce needs, I think depending on the different settings too, we think a lot of in terms of kind of investment in growth and then in retention and support and in, kind of clinical training in that, but I don't know that so stability almost seems kind of more narrow to me than growth in that way or development. Mm-hmm. Can we talk about what we meant here for stability?
Sure. Yeah.
Margareta, do you want me to take a stab at this one?
Sure, go ahead.
I think this is within the larger framework of OHCA. I think there was a concern that setting a cost growth target would have a negative impact on workforce when in fact when in fact the goal is to increase investment in primary care. So the phrase workforce stability probably deserves further investigation than what we have time for, but it also included a recognition that the workforce will continue to reconfigure, whether it's because science improves, we no longer have people in the hospital for a week after they have their gallbladders out, or whether, and we're better at managing asthma and hypertension than we used to be, or whether it's because we realize that where we've been spending money on behavioral health is not the right way and we should be doing more of something different. So it encompasses all of that discussion.
Yeah, that's really helpful, Beth. Thank you. Because it definitely helps to hear more about kind of the thinking behind where it comes from. And I'm glad to hear it sounds like it's an ongoing conversation. So that's helpful. Thank you. Appreciate that.
Sure. Thank you. Thanks, Beth. Kirsten, go ahead.
Thanks. I would second Beth's point about not limiting the idea that people are getting help in the community, not in correctional facilities, but in other restrictive settings, maybe is another way of just saying it. In terms of accessible, I think a couple of other features that are really important, in addition to sort of just saying available when needed, that we are actually working to reduce the delay between the onset of symptoms and getting treatment. So, there's a lot to say there, but not just available as in I call up and I can get an appointment, but actually getting comprehensive treatment for the symptoms as soon as they show up instead of the many, many years most people wait to get access. And then I think both in terms of kind of between comprehensive and accessible, this idea of services across the continuum, but that it shouldn't matter where you live to have that continuum available to you. So kind of geographic equity in the access to the different types of care that people might need.
Thank you. Yeah, great thoughts. And Amy, go ahead.
Can you hear me okay?
Yes.
Okay, great. Do you mind, Margareta, to go to that slide? Was it slide 21? Was it the framework slide? And because I'll refer to it, or maybe it's slide 22.
This slide?
So yeah. I think so agreeing with what I've heard so far, I would like to see, we're talking about truly making an impact finally in our state regarding behavioral health and outcomes. And I would really like this group and all of our leaders to really focus on that word outcomes and to emphasize the point that it is health outcomes, and yes, it's behavioral health outcomes. And when I looked at this slide, I saw the system-wide behavioral health goals. We read left to right, and the things that we cared about or that we keep talking about are on the far right. So can we start with health outcomes? Can we start the conversation? Because then the other subsequent slides start with affordability first, right? If I recall the slides correctly, and then again, outcomes, quality. That's again the last thing that we talk about. And I really want us as as a group, as leaders within this state, if we're really going to propel this and make a mark and truly serve our patients, our members with respect to behavioral health, that we focus on their health outcomes first and foremost. And the way that we present, the way that we organize our thoughts, the way that we come together in meetings and briefings, I do think we should make a point to put that first in our conversations. And maybe it's just a logistical thing, but I do think as a country, we don't focus on outcomes as much as we do other things. And perhaps if we did focus on outcomes, we focused on coordination, we focused on the access, the integration, the collaboration of services, perhaps the affordability piece, would be last, because it kind of does follow that way. But unfortunately, our framework, the way that our healthcare system is set up, it's not that way. So I just try to, input a voice when we are trying to do something pretty substantial in this state on a topic like behavioral health, to continue to remind folks it is about health outcomes. That is the priority that we should be focused on from a patient, from a provider, from an overall service system perspective. So that's just my 2 cents.
Thank you, Amy. Yeah, really appreciate that framing, and we can think about how to restructure or reframe some of both our conversations and our slides to reflect that. And Parnika, I'm going down the list. So.
Yeah, thank you. This is Parnika Saxena. I'm representing the California State Association of Psychiatrists. I had a couple of different thoughts about some of the things that were just recently presented. So the first thought I had was about access, and I think it's good to think about comprehensive access. But I think one important thing to think about is that when we are offering access, there's appropriate triage. So for example, having access to an emergency room would be access, but if you went in with something that wasn't truly emergent, which often happens for people, especially over the weekend when their outpatient physician isn't available and really what they need is a med refill, or let's say they don't need to be admitted to the inpatient unit, but or it's not a true psychiatric emergency, but what they need is a slightly higher level of care. What ends up happening is that the patient ends up waiting for hours in the emergency room to get to the right door, so to say. So I think figuring out a better way of providing access to triage people to the appropriate level of care would be something to consider. I think that would also reduce, because the longer somebody's in the emergency room, the longer the emergency room or the health plan is going to bill for that, as opposed to somebody who needs a med refill. They don't need to be in the ER for 8 hours, but they'll still spend that amount of time, and it will be an inappropriate utilization of resources. So that's one thing. And another thing, maybe this branches into access, is correct information. So one of the things I feel as a psychiatrist is a big issue is that when somebody is looking for an outpatient provider, and let's say they go to the insurance to look at directories, those directories are very seldom up to date. Whether it's a psychiatrist, whether it's an MD psychiatrist, it's a nurse practitioner, or a psychologist, therapist, whoever it might be, it is so often inaccurate. And it should really be on the insurance companies to update it. But unfortunately, that doesn't happen. And people waste so much time in finding one, which I think is a bigger travesty, given the fact that we already have limited access to outpatient resources. And this does end up hurting people much more, especially people who can't afford to go to private practice psychiatrists, who usually will keep things up to date when it comes to what insurances they're taking. So that would be something that I think is an issue that's not just a problem in California, but all over the country. But that would be something that I think would, again, reduce the amount of wait times to see an outpatient provider, which in turn reduces the utilization of emergency rooms and higher levels of care. And the last thing that I wanted to point out was about workforce stability. I mean, I know that we can talk so much about it, but some things that I personally think, because as a psychiatrist in the last few years, especially through the pandemic, have seen things change dramatically, where there's just so many people who got burnt out, and people continue to getting burnt out even though the pandemic is over. The mental health epidemic is not. And what ends up happening is that a lot of people have left jobs at FQHCs, at community health centers, because the workload has become unsustainable. And one of the things that's made workload unsustainable is having a lot of documentation, a lot of things that we need people to document for even better patient care outcomes. So one thing I wonder if we could look at as a part of this work group is whatever we are planning to do, whether it's to improve data collection and to improve further care, I think we should be mindful of how much data collection, how we're doing the data collection. I think we should be mindful about how much of the onus is going to be on providers, so they can actually provide care rather than spending all that extra time documenting. Because I remember when I was in FQHC, when there was one extra flow sheet I had to check on, that's frustrating when you have 20 patients a day. So I think that should be something. So I guess overall, I always try to think about reducing paperwork and load, and definitely reducing redundancy and duplication of data, which quite frankly happens very often. The final thing would be, which I mentioned in a previous comment, so I'm glad that we're trying to get data from Medi-Cal, is a lot of people who are on the so-called periphery who don't get listed through commercial plans and maybe Medicare Advantage are people like peer specialists, recovery specialists, community health workers who play such an important role in helping patients and helping reduce more acute utilization of services for people with SMI. If we do not take that into account, I think we will be misrepresenting the behavioral health utilization as well as the financial utilization overall of services, not just in California, but again, I think this is something that I would say is true to to our entire country. So those were just some things that I wanted to point out.
Great, thank you. I took notes of the kind of key pieces you noted there, and I think we can come back to them, and we'll as we're updating, and potentially broadening some of the goals that we look at, we can include some of those pieces. And I think your last note on including a broad range of behavioral health providers in our work, something we are definitely looking towards. And let's see, Hector, go ahead.
Thank you. Yeah, just really quickly, I'm wondering if the goal of behavioral health integration, promoting integration, is a little bit too limiting in the sense that it's specific to primary care, and I wonder if there should be a role for OHCA in evaluating the impact of having all of these systems in place for mental health and substance use, and how that is impacting people's access to services for beneficiaries, right? Of course, we all know that's a big issue in Medi-Cal, where people have access to the SED services with one plan or one system, and some mental health services with another system, and some other mental health services with the managed care plans. So there's something about integration here to think about, right? Integration at the plan level. I think that also goes to the question about provider networks, right? And how those networks are coordinating, right? Coordinated or integrated, and people can access different providers or services without having to navigate between the different systems. I'm not sure if the specific goal should be promoting integration, although I have my own thoughts on that, but at least evaluating the impact of such a system that I think it's so prevalent in California, perhaps to a larger extent than other states, that degree of separation between the systems.
Sure, Hector. Yeah, I think that's an important point in terms of integration, or coordination is not just between behavioral health services, primary care, but there could be lots of different avenues for improved coordination and integration across the entire healthcare system. And Catherine, go ahead.
Hi, thanks. Catherine here at the California Healthcare Foundation. People have said some of my thoughts, but I think there are a few, looking at that same goal slide, this one, a few things I think the goals are good and they're high level, which is fine. A few things that seem particularly salient in the behavioral health context that I just wanted to call out. Hector made one of my points about that question of integration, both this kind of large systems integration and then maybe particularly the integration of substance use disorder and mental health services, more specifically than the bigger systems issues. Even that, I think, is worth calling out in addition to integration with primary care because of the high rate of co-occurrence of illness. A few other things. In affordability, I think we talked about it earlier, but this question of affordability really, and maybe specifically calling out the question of out-of-pocket spending and or to flip it, affordability, including being able to use your insurance to get care, is sort of what I'm thinking of there. I think Kirsten called out geographic disparities, and I do think that's particularly important in the public system where we have a lot of optional services and different programs of care. I don't know how that plays out on more the commercial side that we're going to look at first. When we talk about under accessibility, culturally responsive, again, I think maybe a specific focus on language here is important. I know that's probably included in what's under culturally responsive, but it does present such a barrier to care for so many Californians not to have in-language service in mental health and substance use care. So I might call that out. And then I think, again, under equitability, it's minor, but I think I would want to flip the order of these points and put the disparities in access, utilization, and outcomes up first. I think we all agree about wanting reduced stigma and discrimination, but I think it's a less important goal of our work and of the healthcare delivery system. You know, in an ideal world, maybe that flows from a better care system, but I want to stay really focused on what we can do. And then last thing I'll say is to that point on slide 2 down, 23 maybe. I just want to say I really like that slide about how, how OHCA can better support. I think that's very helpful and specific, and really like that one. Thanks.
Thank you, Catherine. And yeah, really appreciate all of those points. And we can look to maybe build out this slide with a little bit more detail, but recognize that, we won't be able to probably put everything on one slide in terms of what what all the goals are across our work group. But we'll try to distill and incorporate, the key themes of the conversation we had today. And can kind of pull out, maybe there are potentially more details as well that we could pull out from the HHS policy brief into the slide. And I think next on the list I had Kevin. Please go ahead.
Yeah, thanks. Well, I'm learning a lot from all the comments and insights here. It's just, I think you all have made great headway in creating some frameworks and clarifying some things, but every time we dive deeper, it's just clear the complexity of this particular topic is quite substantial. But I think this is great for making headway. There's one other dimension that I'm realizing is it's a really heterogeneous type of conditions that are being addressed in behavioral health services. And I wonder if that's a dimension that might be helpful to kind of include on a matrix like this. So, in my experience as just a primary care clinician, I do a lot of my work in the county system. It's very different services and needs for people like adults with serious mental illness, like schizophrenia, psychosis. Then there's these very prevalent but less severe mental health conditions, anxiety, depression, traumatization of life. And then we haven't even talked about, there's a whole nother, and then in the adult, then there's the behavioral health, which has a range of people with some really serious substance disorder, particularly, let's say, opium, amphetamines. Then there's alcohol use disorders, which often are more integrated in primary care settings. And then the whole other area we haven't talked about is children's needs. And I think conditions like autism would fall under the behavioral health scope. And that's a whole nother, range of people providing the care, the context, the kind of needs. So I'm wondering, particularly when we think, okay, where would we prioritize where some of the needs are greatest? These are going to be some choices. Is it partly with severe mental illness, very severe substance use disorders? Is that some of the most pressing issues? Is it more common issues that may not have people winding up in the hospital or with really poor well-being and functional status, but are very common? So I think it's something we may need to think about in addition to all these other issues, because it's going to be very different analysis and understanding and strategic directions for differentiated by the type of conditions we're talking about in this very heterogeneous realm of behavioral health.
Thank you for flagging that. And I think that's a little bit of a preview for some of the discussion we will have in terms of the definition and defining behavioral health. So looking at diagnosis and services. And so we will definitely get into some of that. I don't know if Mary Jo or Bob, you wanted to flag anything there about what we might discuss in upcoming meetings.
Sure.
Go ahead,
Bob.
Mary Jo.
No, please.
I think it also goes to the the benchmarking task. The idea of having to make choices about where to prioritize. Those are to some degree policy choices, and the setting of the benchmark directs where the energy will go. So I think in addition to the definitions of kind of what's in and what's out, kind of at the margins of behavioral health care, the discussion, which comes a little bit later about what the benchmark should be, will really pick up that theme.
Thanks, Bob. And I think Carrie, I think you are next. Go ahead.
Thanks, Carrie Sanders with CPEN, and I really appreciate this conversation as well, and a lot of the comments that others have shared, which we agree with too. Just two comments I wanted to echo the comments by Catherine on culturally and linguistically responsive care. And we would appreciate a focus on, I think it's important to focus on in-language care, and how access to that or not access to it can overlay with out-of-pocket spending and out-of-network care, specifically, to what extent are consumers paying for care in language or paying for culturally responsive care because they can't find someone in network that is able to treat them. So I think that is, one important area that, we would love to see elevated. And then I think just in regards to measuring outpatient care, also appreciated some of the earlier comments on the importance of measuring services that are provided by community health workers and peer sports specialists, and would just encourage us as we define outpatient care to really define that, to consider defining it broadly to include that type of community preventative care that is also, I think, really important, and it doesn't neatly fall in the sort of clinical care perhaps model, but things like support groups or faith-based counseling, or the types of sort of community preventative models that exist that are able to capture folks where they are and provide services, and also, frankly, to reduce some of the stigma that I think we talked about earlier when we, invest in these types of community based and community preventative services. Thanks.
Thank you, Carrie. That will definitely be a conversation in terms of our definition. So getting to those few, those pieces that you mentioned. And I think Beth,
Yeah, just a couple of points. We have lots of other sources of information in terms of where need is from the rest of state government, whether it's CalPERS or DHCS, or I see Dr. Soni from Covered California as well. So I think we've got a lot of rich information. I do also think that the issues that bubble up in the legislative process are an important thing to monitor. And to the extent that I'm thinking here specifically of autism, which was treated as something that wasn't a problem until a lot of families made it clear that it was a huge problem. And in the 10 or 20 years since it became a benefit, it's been a long transition is what I'd say. So I just think that all those are sources of information, and wherever we set the targets and the benchmarks, they will have the expectation for behavioral health was that this would be a very hard topic and we would have to learn over time. So it's whatever we're doing, we should expect to iterate in the future.
Yes, thank you. That's a really important flag. And I know there's kind of also some new active work going on that we that may impact our work currently. So we are trying to pay attention to all of everything that's going on kind of across the state and the legislature, and welcome you all to raise things that you think impact our work as well. And since we only have about 2 minutes left, we heard lots of feedback on the goals and ways we could adjust these to kind of be a bit more expansive and more detailed. But if you all think of anything else, please let us know. You're welcome to email me, and we can we are happy to collect your feedback via email and or set up offline meetings if that's of interest. So to wrap up in our last minute or two, just wanted to provide a preview of our September meeting. So in our September meeting, we'll get into more details of a lot of the questions we previewed today and that you all raised in terms of key decisions for measuring behavioral health spend. So we'll introduce a measurement framework. We'll consider trade-offs for key decisions, and attempt to start defining behavioral health diagnoses, services, providers, and care settings for the measurement and reporting purposes. So we will dig into a lot more details in September. And then one note, did want to flag that we are planning to reschedule the November work group meeting. And I think it's due to a conflict with our board meeting, but yes, so the Healthcare Affordability Board meeting is on November 20th. So we are planning to reschedule this meeting to Thursday, November 21st at the same time. If that presents a challenge to many folks, please let us know and we can think about other dates. But that seemed like the date that would work for several folks. So please let us know if there are any major concerns with rescheduling to that November work group meeting. And now we are at the 10:30 mark, so really appreciate all of the discussion and feedback today. It's been incredibly helpful. So we will update our goals and maybe make some other minor revisions to some of our other materials, and then we'll dive into more decisions in September. Thank you all. Hope you have an amazing day.